For most seniors managing their health carefully, there is a familiar rhythm to it. Annual physical, blood work, blood pressure check, cholesterol panel, a review of the numbers, a conversation about what is in range and what needs watching, and then, if everything looks reasonable, a quiet reassurance, you are doing well. Keep doing what you're doing, see you next year. That reassurance feels earned. Most seniors over 65 who are actively managing their health have made real effort. The medication adjustments, the dietary changes, the regular check-ins, they have taken the tests their doctors recommended. They have done everything right. But here's a question very few doctors ask and even fewer patients think to raise. What if doing everything right still misses something? What if the standard tests, blood panels, ECGs, routine checkups are measuring the right things but not all the right things? What if there is a specific dimension of cardiac risk those tests were never designed to detect sitting quietly in the background while every number on the panel stays green? This is not theoretical. It is a documented gap in standard cardiac screening, one that cardiovascular researchers have been addressing for years, but that has been slow to reach the routine appointments where most seniors make decisions about their health. There's a scan, a specific non-invasive imaging test that takes less than 15 minutes, requires no needles and no preparation, and produces a single number that tells you something no blood test, ECG, or standard checkup can tell you: the actual visible accumulation of calcified plaque inside the walls of the heart's own arteries. Most seniors have never had it, many have never heard of it, and most appointments end without it ever being mentioned, because there is one scan that reveals what standard tests often miss, and most people don't even know to ask for it. By the end of this video, you will know exactly what this scan is, what it measures, who should consider getting it, how to access it, and what the results mean for your cardiac risk going forward. No complicated medicine, no prescriptions. One test explained completely, so you can have an informed conversation with your doctor about whether it belongs in your care plan. I am also going to explain what to do with the result, both if it comes back low and if it comes back elevated. Knowing the number is only the beginning. What you do with it is what matters. And I want to hold one part back until later. The specific score threshold at which cardiac risk escalates sharply, and the lifestyle intervention the evidence shows can slow progression even after a score is elevated. It is not what most people expect, but first, let me explain what this scan is measuring and why it sees things other tests cannot. Think of your coronary arteries as pipes carrying water to the most important room in the building. Standard blood test measures what is in the water: the cholesterol, the inflammatory markers, the blood sugar. Useful and important, but it tells you nothing about the condition of the pipe walls themselves. Over decades, the inner walls of the coronary arteries develop deposits: fat, cholesterol, inflammatory material, and over time, calcium. That calcium is what makes an advanced deposit measurable by imaging, the body hardening and calcifying damaged tissue in an attempt to stabilize it. A coronary artery calcium scan, a CAC scan, uses low-dose CT imaging to detect and quantify exactly that calcium. It produces an Agatston score, a number reflecting the total amount of calcified plaque in the coronary arteries at the time of the scan. A score of 0 means no detectable calcified plaque. A score above 100 indicates moderate disease. Above 400 indicates extensive calcification and significantly elevated cardiac event risk. Here is why this matters. Two people can have identical cholesterol levels, and one can have a CAC score of 0 while the other has a score of 350. The blood test would treat them the same. The CAC scan would not. It adds a dimension no other standard test can access: a direct look at the walls of the pipes, not just the water running through them. In 28 years of cardiac practice, the CAC scan has become one of the most valuable tools in my clinical toolkit for assessing risk in patients over 60, particularly in those who appear low to moderate risk on standard panels but have a family history, a history of smoking, or other factors that make me want to see what is actually happening in the arterial walls. I have had patients with entirely normal cholesterol levels come back with CAC scores above 300. Without that scan, they would have left my office reassured. With it, we were able to initiate a genuinely aggressive risk reduction strategy before a cardiac event occurred. I've also had patients whose cholesterol numbers were concerning but whose CAC score came back at 0, giving us important reassurance that the arterial walls were not yet showing damage, and allowing us to manage the situation with lifestyle intervention rather than immediately escalating medication. The CAC score changed the conversation in both directions. It is not perfect, no single test is, but as a risk stratification tool for adults over 60, the evidence behind it is strong, and the case for making it more widely available in routine senior cardiac care is, in my view, compelling. What most people don't realize is that the CAC scan is not experimental, not new, and not difficult to access. It has been available for years. It is covered by many insurance plans, and self-pay options are often affordable. It takes less than 15 minutes, and the information it produces can meaningfully change how both you and your doctor understand and manage your cardiac risk. Here is everything you need to know about it and how to use the result. Let me ask you something. When you hear the words heart scan, what do you picture? Something complicated, expensive, involving dye injections and a waiting list? The CAC scan is none of those things. It is a non-invasive CT imaging scan, no needles, no dye, no preparation required. You lie on a table, the scanner passes over your chest for approximately 10 to 15 minutes, and the imaging produces a detailed picture of calcified deposits in your coronary arteries. No exercise stress involved, no fasting, no recovery time. It does involve a small dose of radiation, comparable to a mammogram. Not zero radiation, which is worth knowing, but the dose is low, and for adults over 60 with any cardiac risk factors, the information it provides typically far outweighs the minimal exposure. What it is not? It does not measure heart function or blood flow in real time. It measures the static accumulation of calcified plaque in artery walls, a structural marker of cumulative arterial disease over years or decades. I describe it to patients as a snapshot of the walls of your coronary arteries. Everything else we check is about what is happening in the bloodstream. This is about what has been happening in the walls for the past 20 or 30 years. That is a completely different and equally important question. What to do? Search for CAC scan or coronary calcium scoring at imaging centers in your area. Self-pay costs typically range from $75 to $200. Ask your doctor whether they would find the result clinically useful. Most will. Let me ask you something. Are you over 60 with any of the following? A family history of heart disease, a history of smoking, high blood pressure, elevated cholesterol, or diabetes? If the answer to any of those is yes, the CAC scan is a conversation worth having. Current cardiovascular guidelines suggest the scan is most useful for adults aged 40 to 75 who are considered intermediate risk on standard calculators, meaning their panel does not clearly place them in high or low risk, and additional information would help guide decisions. The case for seniors over 60 is particularly strong. By 60, even relatively healthy people have had decades during which arterial change could have been occurring silently. A CAC score of 0 in someone over 65 is genuinely reassuring. It suggests that despite years of exposure to the usual risk factors, the coronary arteries have not developed significant calcified disease. Conversely, a high score in someone who appeared low risk on standard panels is an important signal, one that changes management in a way that waiting for a cardiac event would not. The patients I most want to have a CAC score are those in the middle, not clearly high risk, not clearly low risk, trying to decide whether to start a statin or how aggressively to pursue lifestyle change. The CAC score often breaks that tie clearly and definitively. What to do? At your next appointment, ask, given my risk profile, would a CAC score change how you would manage my cardiac care? The answer will tell you whether the scan is appropriate for your situation. Now, what I'm about to share next is something most doctors don't spend enough time on when they deliver a CAC result. The score is just the beginning. What you do with it, particularly if it comes back elevated, involves a specific strategy that the research supports strongly, but that rarely makes it into a routine appointment. Stay with me. This part is where the scan becomes truly useful. Let me ask you something. If your doctor handed you a number and said this is your CAC score, would you know what to do with it? Most people would not. Here's the framework. A score of 0 is the best possible result. No detectable calcified plaque. For adults with no other major risk factors, it is associated with very low cardiac event risk over the next 5 to 10 years. It does not mean the Arteries are perfect, but it is genuinely good news. A score of 1 to 99 indicates mild calcification, early arterial change that warrants lifestyle attention, but not typically medication escalation. A score of 100 to 399 indicates moderate disease, the range where conversations about statin therapy and aggressive lifestyle intervention become most important. A score of 400 or above indicates extensive calcification and significantly elevated risk requiring urgent management. I've seen patients receive a score of 450 and feel deeply motivated to change things they had been resistant to addressing for years. Sometimes, a specific number that belongs to you and your arteries does what years of general advice cannot. It makes the abstract concrete. What to do? Ask your doctor to explain your result in the context of your full risk profile. Request it be included in your medical record as a baseline. A repeat scan in 3 to 5 years can show whether progression is occurring and how well your interventions are working. Let me ask you something. If you received a CAC score above 100, what would you expect your doctor to recommend? For most people, a statin prescription and a stronger conversation about diet. While statin therapy is often appropriate, it is only part of the evidence-based response. Here is what the research actually supports beyond medication. First, a consistent 20-minute walk after your largest meal measurably reduces post-meal blood sugar spikes, one of the primary drivers of ongoing arterial calcification. Second, omega-3 fatty acids at meaningful doses. 2 servings of fatty fish per week or a physician-supervised supplement reduce the inflammatory component of arterial plaque and slow calcification progression. Third, 7 to 8 hours of consistent sleep is one of the most powerful anti-inflammatory tools available. The arterial repair that occurs during deep sleep is the body's primary mechanism for slowing the inflammatory damage that drives calcification. Fourth, and this is the one most people do not expect, chronic psychological stress drives cortisol elevation, which drives arterial inflammation, which drives calcification. This is measurable and consistently underaddressed in standard cardiac care. When a patient comes to me with a CAC score above 200, I don't just hand them a prescription. We go through sleep, diet, movement, and stress systematically, sûrement, because every one of those inputs is directly affecting the score they just received. Medication addresses 1 pathway, lifestyle addresses 4 more. What to do? If your score is elevated, ask your doctor specifically about the non-pharmacological interventions supported by the evidence, not as an alternative to medication, but as an addition to it. The goal is to reduce the rate of progression. Let me ask you something. Have you ever wanted to ask your doctor about a specific test and not quite known how to raise it, without sounding like you had been reading too much online? This is one of the most common barriers between patients and the information that would help them. It is completely solvable. Here is exactly what to say at your next appointment. I have been reading about coronary artery calcium scoring as a risk stratification tool for adults over 60. Given my history and current risk profile, would a CAC score give you any additional information that would change how you manage my cardiac care? One sentence. It names the test correctly, frames it as a clinical question, and puts the decision in the doctor's hands while making clear you are informed and engaged. A cardiologist familiar with the evidence will engage genuinely. If your primary care doctor is unfamiliar with it, request a referral to a preventive cardiologist. Cost note: many insurance plans, including Medicare, cover CAC scanning for appropriate candidates. Self-pay typically ranges from $75 to $200, among the most cost-effective preventive investments in cardiology. Every point we have covered today connects back to one central reality. Blood flow to the heart depends on the condition of the coronary artery walls, and the condition of those walls is something standard tests were not designed to directly measure. Blood flow is everything, and the walls that carry that blood flow are invisible to every test except this one. Cholesterol tells you about the composition of what is flowing, blood pressure tells you about the force, and ECG tells you about the heart's electrical activity, all valuable. None of them tell you what has been deposited in the coronary artery walls over the past 30 years. The CAC scan fills that gap. It looks at the walls. It quantifies the accumulation. With that single number, you and your doctor can make decisions that a standard panel simply does not empower you to make. Let me tell you about a patient I will call Bernard. Bernard was 68. He came for a second. Opinion after an annual physical returned entirely normal results. Cholesterol managed, blood pressure controlled, ECG unremarkable. His primary care physician had told him he was doing well, but a family history of cardiac events in men in their late 60s had been worrying him for years despite the clean numbers. We ordered a CAC scan. His score came back at 387, not 0, moderate to high, a number that changed the entire picture of his cardiac risk, and that his standard panel had given no indication of whatsoever. We initiated a comprehensive response. Statin therapy, a structured sleep intervention, a post-meal walking routine, omega-3 supplementation, and a stress management consultation. 3 years later, a repeat scan showed a score of 412, a progression of 25 points against an expected rate that, given his risk profile and family history, would likely have been significantly higher without intervention. I walked out of my physical feeling like everything was fine. Bernard told me, if I hadn't pushed for a second opinion, I would never have known. Nobody would have ordered this scan. I would have kept calling it good health management. He was right, and he was fortunate. Not every patient pushes for a second opinion. Not every patient thinks to ask the question. You now have the question. Let me make this simple. 5 things to know about the CAC scan. Point 1. What it is. A non-invasive, low-radiation CT scan that takes 10 to 15 minutes and measures calcified plaque directly in the coronary artery walls, producing a single Agatston score. Point 2. Who should consider it? Adults over 60 with any cardiac risk factors, family history, smoking history, high blood pressure, diabetes, elevated cholesterol, particularly those in the intermediate risk range on standard panels. Point 3. Understanding your score. 0 is the best result. 1 to 99 is mild, 100 to 399 is moderate, 400 and above is extensive. Each range has specific management implications. Point 4. What to do with an elevated score. Address inflammation from every direction, medication where indicated, plus post-meal movement, omega-3 intake, sleep quality, and stress management. To slow progression. Point 5. How to ask for it. Tell your doctor, given my risk profile, would a CAC score give you information that would change how you manage my cardiac care? 1 sentence, it starts the right conversation. 5 points. 1 action that covers all of them. At your next medical appointment, ask for a CAC score discussion. You do not need to order the scan today. You do not need to have the full management plan figured out in advance. You just need to raise the question with your doctor and let the conversation begin. That 1 question, asked at 1 appointment, could produce a number that changes how you and your doctor understand your cardiac risk for the next decade. It could surface a risk that your current tests are missing, or it could come back at 0 and give you a level of reassurance that no blood panel can provide. Either way, you will know something you do not know right now. Start there. I want to hear from you in the comments. Have you ever had a CAC scan, and if so, did your doctor explain the result fully, or did you leave the appointment with a number and not much else? Leave your experience below, because your story might be exactly what someone else needs to read before their next appointment. And if this video gave you a question you did not have before, please share it. With a spouse who has been told their numbers look fine, with a parent who had a clean physical last month, with a friend whose family history makes this test particularly relevant, a clean blood panel is good news. A CAC score of 0 is better. Knowing which one you have when making that choice deliberately is what serious cardiac health management looks like. Subscribe to this channel for weekly senior health guidance. Evidence-based, clearly explained, and built on nearly 3 decades of watching what actually protects the heart and what leaves gaps. Everything in this video is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The CAC scan is a clinical tool that should be ordered and interpreted in the context of your full medical history and by a qualified physician. This video does not recommend the scan for every individual. The decision about whether it is appropriate for your specific risk profile is one to make with your doctor. Do not stop or adjust any medication, including statin therapy or blood pressure medication, based on anything shared here. Always consult your healthcare provider before making changes to your treatment plan. If you are experiencing chest pain, shortness of breath, or any cardiovascular symptoms, seek emergency medical attention immediately. The CAC scan is a preventive screening tool, not a response to acute symptoms. Your heart health is a partnership between you and your medical team. This video equips you to be a more informed partner in that conversation.